Well, thank you, Vicki, very, very much for that overview and kind introduction. And I too welcome all the participants today. Time is valuable, and I really do appreciate the time. I think we have an important topic to introduce today, and also some concrete methodology in terms of how we can move forward and make a difference. Obviously, this is going to be more focused on hypertension control, which we're going to see is a tremendous problem, not only globally in low and middle income countries, but high income countries such as ours, as we're going to see. The initial slides I want to make sure that everyone's aware generously come from Dr. Pedro Adunes, who's the director of the Hearts in the Americas program within the Pan American Health Organization based in Washington. The Pan American Health Organization is a subset of the World Health Organization, of course, that's based in Geneva. This program has been going on for almost a decade, and I've been privileged to be part of the program since its initial planning and inception and now implementation since 2013. This slide is no surprise to anyone. This is an overview, of course, of the cardiovascular diseases in the Americas as of 2019. I will not go into detail regarding the slides. We'll be providing you all of these slides for your personal review as well as you see fit. But clearly, not only do we have a number of individuals already with existing cardiovascular disease and increasing new cases, but the prevalence of cardiovascular disease is dramatically increasing, particularly in low and middle income countries, as we change from communicable disease morbidity, mortality, also now to increasing non-communicable diseases, which of course cardiovascular disease is number one. Next slide. This is our data in the United States by obviously a boxed diagram as well as trend studies. The box diagram is on the left, and you can see the largest boxes are in cardiovascular diseases from ischemic heart disease, stroke, hypertension, chronic kidney disease, etc. That comes as no surprise to all of us. However, what was a surprise to me over the last 5 to 10 years is our trends over time for cardiovascular disease burden. As you can see, we've done a wonderful job over the last 30 to 40 years of decreasing cardiovascular disease burden, and we could even be more specific, morbidity and mortality. However, that burden and morbidity mortality reduction has dramatically leveled off. And we're kind of stuck, as you can see in the tail end of the graphs on the right-hand side. We're going to specifically talk about hypertension in that it's not only plateaued, but I'm going to show you some data from the NHANES report that demonstrates it's actually going back up. Next slide. Well, what is the HEARTS program? And again, one of the components of this, the objectives of this webinar today is to introduce us not only to the Hearts in the Americas program, but the Global Hearts Initiative, but also to focus in on and broach one of the key approaches that Hearts would bring to the table. The Global Hearts Initiative is out of the WHO, and of course, Hearts in the Americas is a subset. It consists of 3 components, if you will. On the left, you can see there's a population-based approach, which includes smoking cessation, exercise, sodium reduction, and replacing trans fats. On the bottom, it also delivers a chronic care model. The importance, however, for today is the health services clinical approach, which we also call the technical package or the HEARTS technical package. It consists of 6 modules, and obviously they follow the acronym of the word HEARTS, from healthy lifestyles to evidence-based treatment protocols to access to essential medications and technology, risk-based management or cardiovascular risk assessment, team-based care, and systems for monitoring. Each one of these modules has robust information, data, and actually a blueprint, if you will. We're going to just introduce very, very briefly towards the end of the webinar, the E module, which is the evidence-based treatment protocols module, which we laughingly or euphemistically say is the heart of HEARTS. If we're going to start using HEARTS, that is where we started. We started with the evidence-based treatment protocols and the E module of the HEARTS technical package. Next slide. Well, where are we now? We started in 2013 with no countries. And we all met in Miami, and we just discussed what could we do if we wanted to embark upon the journey of increasing hypertension control rates in low and middle income countries, particularly in Latin America and the Caribbean. Well, look where we are now. This is already old data, and it's only about a year and a half old. We have 22 countries implementing HEARTS. More than 1,300 primary healthcare clinics are implementing HEARTS, and we already have over 5 million people covered. And you can see the dramatic exponential growth of the HEARTS program. And the reason it's growing is one clear reason: it works. And countries now we're at a tipping point where more countries want to join HEARTS than we have the individuals, expertise, energy, et cetera, to even implement. So, but we are still continuing to implement, and we're up to 28 countries now. Next slide. Well, this is the technical pillars of HEARTS in the Americas. And you can see the number one pillar on the left, which we will discuss a little bit more in detail today, but much more in detail as the webinar series evolves, is standardized treatment protocols and medications. But their other pillars are measure the blood pressure accurately with validated devices. HEARTS offers a robust training and education and certification program. It also lends to data standardization and data utilization. It focuses also on implementation research and program evaluation. And of course, the end result is innovation in organization of team care and health systems care, from the practice to the system to even the state, and then also the country. Next slide. Well, there are guiding principles of HEARTS in the Americas. And obviously, this is a slide I would like you to review at your leisure, but it's a gradation, guiding principles, if you will, from country or systems ownership to a guiding principle is it must be simple and practical or it will not work. Of course, it must be evidence-based. There must be accountability. There has to be continuous learning. We've already learned so much over the last 7 to 8 years, if you will, that HEARTS has changed even since its inception, and that would be expected and actually welcomed. It should have long-term sustainability, and now we're almost up to a decade, and it is clearly sustainable, and it has to increase the capacity of our primary health care network. HEARTS is a primary care-based modality, if you will. Our specialists are absolutely critical, and they're involved, and they're upon the journey with us. But this is a primary care initiative, and I want to make that perfectly clear. Next slide. Well, this is sort of the implementation strategy. There's a module, there's a guide and essentials for implementation of the HEARTS program that's robust, and that's on our website, of the HEARTS website of PAHO, and we can provide that to you. But basically, it's a strategic leadership, systematic planning, and continuous quality improvement, as we've already talked about. We're always implementing, we're always monitoring, and of course, we're always assessing and changing where needed. Next slide. Well, so what's the difference? Why HEARTS? And what does HEARTS bring that's different? Well, we've had a traditional model, as we're going to discuss in more detail, that has only brought us so far. The traditional model has been specialty-based. HEARTS in Americas is primary care-based. The traditional model has been physician-centered, and although physician still is the leader and the supervisor, HEARTS in the Americas offers a team-based care and task-shifting approach. The traditional model is non-standardized, somewhat centered on the specialist, particularly in low and middle income countries. HEARTS is standardized and focused on primary care. The traditional model offered individualized decision-making, and you're going to see in our HEARTS, especially the E module, that the HEARTS E module is all about standardized clinical pathways and specific treatment protocols. Blood pressure measurement, of course, has been non-standardized. HEARTS makes sure that the devices we use are validated, and that the education of the individuals taking that blood pressure, of course, they're certified. There's a treatment approach where the traditional model was individual preferences, and obviously HEARTS is going to be standardized, simple, and directive in terms of an algorithm. And of course, we now recommend in the HEARTS model, integrating cardiovascular risk assessment and also clinical monitoring of performance evaluation. And that's in the day-to-day management of our primary care centers. Next slide. Well, these are all the different plethoras of tools that are available in HEARTS, and I will not belabor them, except that they're robust and there's many. We will discuss many of these in specific webinars upcoming. And by the way, these webinars will be given by the individuals that led each of these components. And the one in the center is the hypertension clinical pathway. Next slide. And this is the hypertension clinical pathway, which is sort of now the culmination of lessons that we've learned to start putting the pieces together. Instead of having separate pillars, now we can offer a one-stop, if you will, clinical pathway of importance in terms of what things that we believe have made the difference in increasing hypertension control. And it's an ABC model. There's going to be a specific webinar on the hypertension clinical pathway, but it consists of accurately measuring blood pressure, measuring and monitoring cardiovascular risk. And again, the treatment protocol, the treatment algorithm is centered for a reason. It is job number one. It makes the difference in rapidly and increasing our hypertension control rates. Next slide. But there are challenges, of course. The challenges are we have to break our previous inertia, whether it's political or individual or systems inertia, and institutionalize HEARTS. We want to improve access to high quality care, including medicines and devices. And even in high income countries such as ours, we know that's a challenge. We want to strengthen our primary care health system, and importantly, its information systems. And again, we want to promote a culture that is based on continuous quality improvement. All of these are challenges. All of us are facing these challenges. I don't care where you are, what country, what level of income, or what geographic area we're in. Next slide. But there's a way forward. And HEARTS will be an institutionalized model of care for cardiovascular management. We're already discussing not only hypertension, but moving beyond hypertension to diabetes, chronic kidney disease, et cetera. And again, it's going to have various platforms, but it's always going to be primary care health center based. Next slide. So what are we really talking about today? And let's shift from an overview of HEARTS to an example of again, it's going to be an overview, but an example of one component of HEARTS that works. And that is the heart of HEARTS. And that's the E module in our technical package, but predominantly that's the treatment algorithm or the treatment protocol with a small standardized formulary. So what we're really discussing is not HEARTS. We're really discussing change. And how do we change organizations that have been doing things, and somewhat well, of course, for a long period of time. There's a gentleman that I learned while I did some business management education, if you will, by the name of Kotter. He's an important individual that in the 1980s, he watched the US auto industry, they were making lots of money, they were doing very well, but he saw storm clouds on the horizon, and those storm clouds, of course, rained, poured, and hailed and snowed in terms of bringing new platforms, new innovations, new manufacturing techniques, better quality control, et cetera. And he watched our industries and the lack of change and developed a plan for change that works from small to large. He developed 8 steps, but the very first step to organizational change or even individual change is to acknowledge that there's a sense of urgency, there's a burning platform. Once that is done, you can see the other steps that Kotter outlined on this slide. But the first step we must take is an urgency and to acknowledge again that there's a burning platform. Next slide. So what's our burning platform today in terms of hypertension? Well, clearly we know this. We know this data. Hypertension is the leading risk factor for cardiovascular disease, no matter where you are now, including globally. Hypertension control rates are dismal. The last Lancet article in 2021 that looked at global hypertension control, it was approximately 20%. And that's what a blood pressure definition of 140/90 or greater. However, this dismal control rate is despite the availability of safe, effective, and affordable pharmacologic treatment. So it didn't make sense. So what we need to do is start an honest discussion with each other regarding how current practices have not been successful. They have taken us so far, and that advance is welcomed, but we're stuck. So we have to examine new opportunities to increase control rates of hypertension, and that is going to also mean doing things differently. And we've all heard this adage: the definition of insanity is doing the same thing over and over and over and over again and expecting different results. It's time for change. Next slide. Well, if that wasn't a burning platform as an overview, this should be for us. The NHANES data is our population-based surveys that periodically, about 4 to 5 years, examines multiple states of health in the United States, one of which is hypertension. The NHANES data has demonstrated that over the last 3 to 4 decades, we have increased our hypertension control rates, and that was welcomed. In fact, the last survey in 2013 and 2014, which showed increasing control rates, we reached a peak of about 54% control in the country. However, the most recent 2 NHANES data sets have now shown ominous storm clouds and a sense of urgency. In fact, hypertension control rates have not increased. In fact, they've decreased to approximately 44 to 47%. And this data starts pre-COVID. That's using the definition of a blood pressure of less than 140/90 as control. What if we use the AHA-ACC criteria of less than 130/80 as control, and our control rates in our country would be only 19%? Well, that would be one thing if it's just a number, but it's not a number, it's outcomes. While we're seeing these hypertension control rates actually now decrease, not solely level off, but decrease, the decrease in control rates are being paralleled now by recent increases in CVD-related morbidity and mortality, including stroke. So if that isn't a call to action, I don't know what is. Next slide. Well, it's amazing that the NHANES report caught the attention of our Surgeon General. And this is in the middle of the COVID pandemic. Surely we had a lot of things, better things we could do, or other things we could do with our energy. But the Surgeon General made a statement and issued a call to action during the COVID pandemic regarding these storm clouds and these decreasing cardiovascular control rates, that we have to redouble our effort, reinstitutionalize a national effort with 3 goals to improve hypertension control. Make hypertension control a national priority, ensure that places where we work, live, and play support hypertension control. That means everywhere. And more importantly, the call to action from the Surgeon General also offers implementation strategies. And strategy 1, to optimize patient hypertension control rate augmentation, is to advance the use of standardized treatment approaches and guideline recommended care, including a small and simple hypertension formulary and treatment protocol. This is right out of the HEARTS textbook. Now, it should come as no surprise, because our founding partner in the HEARTS program was the Centers for Disease Control. Next slide. And this just summarizes. You can go to the Gov website and find the entire call to action from the Surgeon General. But as you can see on the right-hand side, a comprehensive hypertension treatment protocol is the centerpiece. It's now the hearts of the Surgeon General's report, not just the heart of HEARTS. Next slide. Well, this is what we're talking about when we're talking about care and change in care, even in my lifetime, regarding the treatment of hypertension. Not too long ago, there was no care for the treatment of hypertension for 2 reasons. We didn't have evidence-based data to show that lowering blood pressure improved outcomes. And we also, even if we did, we probably didn't have safe and effective pharmacologic agents. However, that changed when new data became available, large studies were published, and we developed an approach called step care to the treatment of hypertension. We'll all remember that if you're old enough. That was to start with a thiazide or thiazide-like diuretic in everybody. If the blood pressure wasn't controlled, add another agent, maximize the doses, add another agent, and so forth and so forth. Step care gave way to a modification called individualized care, which I would suffice to say we're probably still in this phase. Individualized care was really step care with a little bit of a difference in that instead of starting one class of antihypertensives in everybody, you could choose through 3 or 4 classes of antihypertensive medications. However, the premise was the same. Start with one agent, maximize the doses. If you're still not at a goal, add a second, maximize the doses, and so forth and so forth. That takes a lot of time. And as you're going to see, we're discussing a term called time is outcomes. It's not only improving the percentage of hypertension control at a population level, but what also makes a difference is how fast you achieve that control, the rapidity of which you achieve that control in the individual patient, particularly around stroke. That is now what we would like to discuss, give way to a population-based care, where it's a combination of a population-based approach for the majority of individuals with hypertension, while still allowing an individualized approach at the clinical level, if you will, in that exam room when it is absolutely important and necessary. Next slide. Well, what are the barriers to blood pressure control? Why are we stuck? Why are we not improving hypertension control despite, again, the safe, effective, available, and affordable agents that we have? We all know these, and we could probably do 2 or 3 more of these slides. There are patient barriers, there's healthcare provider barriers, and there's health system barriers to improving hypertension control. We're going to discuss the various modules of the HEARTS technical package, one of which again is the E module, which addresses some of these barriers, but when you put the whole technical package together, it addresses most, if not all, of these barriers. Next slide. Well, HEARTS in the health systems is important. Given the magnitude of cardiovascular disease, it's necessary for systems to tackle the underlying common condition. And the systems could be a health system, it could be a clinic, globally, it could be a country. And even globally, it could be a region or the whole or worldwide. One of the most effective, cost-effective ways to address this burden of disease is, again, a primary care approach. And the HEARTS technical package does that. And it can be used in all contexts and countries. As you can see, it transcends demographics. It transcends income. And these are important concepts when you're talking about a population-based approach. It must be available and work in all. Next slide. Well, I'm talking about PAHO, the Pan American Health Organization, and the World Health Organization, but they're not the only organizations that have endorsed HEARTS. In fact, we have a plethora of workers now to implement and expand the HEARTS program around the world. And now we're discussing here in the United States, not only in South Carolina, but our colleague states that are on board today. And you can see these are major organizations, all of which are endorsing HEARTS and moving HEARTS forward. Next slide. And this is the HEARTS technical package, a little bit more detail. Again, the modules follow the acronym HEARTS, so there are 6. And we're going to just superficially discuss what does the evidence-based protocol module or the E module bring to the table. Again, in the webinar series, we're going to be discussing all of these modules. Next slide. And this is a slide that demonstrates putting together the technical package with the pillars and with a program implementation to show that the parts are connected. And again, we're going to take a lot of time and discuss these parts individually, but also as a collective. Next slide. I said that the technical package consists of 6 modules, but what we found, and one of the lessons learned, is you cannot jump into all 6, that the modules can be prioritized. And the very first module to look at, discuss, and potentially even implement where needed and where there are gaps is that E module, that evidence-based module. Then you can move on to module 2, module 3, etc. And that's what we did with HEARTS. We didn't start with all 6. We started with 1. Now, of course, 8 or 9 years later, it's robust, and we are delivering all the technical packages in those 22 to now 28 countries that I already showed you on the map. Next slide. So this is the same slide I just showed you regarding barriers, but now specifically targeting what barriers does a standardized formulary and a stepwise standardized treatment protocol address specifically? Well, number one, and the evidence is clear, it clearly addresses poor adherence to treatment. It also, on a provider level, it absolutely addresses clinical or therapeutic inertia, and it addresses lack of adherence to treatment guidelines. At a health systems level, it addresses and improves issues related to supply, distribution, and cost, which is important to all of us. And it addresses our complex medical regimens. Why? Because the regimens are simple. Next slide. And here's why a hypertension treatment algorithm is key to not only a population-based approach, but key to rapidly improving hypertension control rates in any organization across any income strata or geographic strata, which I'm going to show you some data. Number one, it's a critical strategy to increase hypertension control rates. We know it works, and we know it works rapidly. As already mentioned, it addresses clinical or therapeutic inertia because it guides us in terms of when and how rapidly to make medication titrations and or add additional medications when needed. It's simple, straightforward, and standardized. It's transportable within a health system or within a clinic or within even a country. And it can be adopted at any level, from a local level to a countrywide level, and also to a regional level, as we're now experiencing with Hearts in the Americas, and of course, the Hearts Initiative worldwide. But just like there's guiding principles to the Hearts program, there's guiding principles to the algorithm. What guiding principles must the algorithm follow? Number one, and I've said it over and over again, I'm a general internist. Yes, I did a hypertension fellowship, but that's my last boards or terminal boards is the American Board of Internal Medicine. It must be primary care based. That's where our hypertension patients live and will be controlled. There's specialty-based clinics, of course, for the exception, which brings me to the next point. The algorithm is for the patient rule, not the patient exception. We all can think of patient exceptions, but if you really think about it, 85 to 90% of our individuals in our practices with hypertension are the rule. They're not the exception. They can follow an algorithmic standardized treatment approach. And when they deviate or when they don't fit, that's the exception. That's when individualized care should take place, including collaborative, collegial relationships with our specialists. They have to have few medication titration steps. That improves rapidity to control. And they must be linear with no branch points. We've all seen algorithms with arrows that go every which way. You cannot follow those, and they are ignored. So an effective treatment protocol, in this case in hypertension, must have few steps and be linear. And also, a guiding principle is to start with 2 antihypertensive medications, not 1, upon the initial diagnosis of the hypertensive individual. That's change. And that gets us back to Kotter. Why? Because there's a burning platform. And when we start 2 antihypertensive medications from complementary classes, we're going to use half maximal doses. And that, if you use a half maximal dose, you only then entail 1 titration step to achieve maximal doses of those 2 agents. Then you can add a 3rd or a 4th, et cetera, as indicated. And if possible, those 2 antihypertensive agents should be, or preferably could be, or in 1 single pill, either called fixed dose combination or single pill combinations. However, most of our Hearts clinics, programs, and countries do not have single pill combinations. So we are actively dispensing 2 separate pills upon that initial diagnosis at half maximal doses, and it works. But it's preferable to have it in a combination. Next slide. Well, this is an algorithm from our Kaiser Permanente colleagues in California. They saw that their hypertension control rates were dismal, and they said, we have to do something different. And they developed an algorithm that is still in place, I think now 13 or 14 years later. Their algorithm starts with an ACE inhibitor and a thiazide diuretic in combination, lisinopril and hydrochlorothiazide. There's rapid titration steps that are linear. If the patient's still not controlled, they add a calcium channel blocker, amlodipine at half maximal dose, 5 milligrams, and then titrating upwards. And then they also have algorithms if you're still not controlled after 3 medications in complementary classes at maximal doses, and we would call this resistant hypertension. Next slide. One more, Vicki. And this is the data. This proves it works. This was implemented between 2013 and 2014. Prior to that, and what was the sense of urgency? What was the burning platform? Their hypertension control rates were 44%, far below the national average at the time of 55%. And they said, we have to do something different. And then they implemented, obviously, the hypertension protocol that we just reviewed. Instantly and rapidly over the course of implementation, you can see their control rates rose to initially 70, 85, 80-ish% and continued to increase to almost 90% by 2013 in 1 decade. And this data has now been sustainable, and it's been accompanied by a dramatic reduction in cardiovascular outcomes. So it can be done and it can be sustained. Next slide. And I think this is the most important slide from the Kaiser Permanente experience. When you use two antihypertensive medications together that are complementary, and you start them initially, you lower blood pressure the same in all demographics that they've measured. Whether you're non-Hispanic white, whether you're Hispanic, whether you're Black, whether you're Asian, Island, Pacific, or you're other, notice the control rates are all identical, between 80 and 90%. If you ever want to address disparities of health care in terms of lowering blood pressure and controlling blood pressure, and then of course outcomes, this is essential. If we don't do this for any other reason, this data is the reason. Next slide. So these are our early examples. This is our start. We started with one country in Barbados. They were our demonstration project. And then soon thereafter, Chile, Colombia, and Cuba joined. And now we're up to 28 countries, as I've already mentioned. Notice that all the founding countries and all the countries today start with two antihypertensive medications upon the initial diagnosis. Now notice they can be completely different. That's because it's important to develop an algorithm that can be instituted immediately and has already medications that are available and affordable. And we're going to discuss further in the webinar series how we can move from the current immediately implementable protocol to a preferred protocol as time goes by. But every country has developed the exact same guiding principles. They've just done it with different agents, which is absolutely okay. Next slide. Well, let's summarize. What have we discussed? What have we learned? Well, when we're transitioning from an individualized care approach to a population-based approach, these steps are critical. Number one, we must use a standardized, simplified approach to hypertension detection and treatment. And that includes initially measuring the blood pressure with validated devices. And we'll discuss that in much more detail in the upcoming weeks and months. We have to develop a primary care-based approach to the patient rule, not the exception. We have to move away from, well, my patient's different. My practice is different. Yes, there are differences within a practice, but not between the differences between practices or even between systems, between countries are small. And most patients are the rule, not the exception. The Hearts in the Americas, and including the technical package, is a comprehensive blueprint across a spectrum of populations that works across a spectrum of economic conditions, from low to high income, geographic entities across the globe, racial differences, ethnic differences, and also including cultural differences. They're important. Culture matters. The launch of Hearts in the Americas can significantly improve the detection and treatment. But more important, what we're really after is the outcomes. Importantly, increase the control of hypertension in our state, in our states, in our locales. And this is important. We're all doing really good things in the health systems. There are other protocols, if you will. There's other programs. Hearts in the Americas is in addition to. and complementary to programs we already are doing and already are in place. And if they're already working, if it's not broken, don't fix it. But we do know that system-wide, we can do better. And so Hearts in the Americas could be an addition, and it could fill in gaps where needed. And we're here as advisors to help in any way possible.